Hello, good evening, everyone. Thank you for joining me tonight. Just a couple minutes, I'll be introducing our guest speaker and we'll get started right into the presentation. I'm hoping she can share her screen with us. We'll find out in a minute. Okay, it's 5:30, we'll get started. My name's Oscar Sida. I'm sure you all know me. I'm the Human Services Program Coordinator and Core Faculty for Human Services at GBC. And tonight is our first symposium of the spring semester. We'll have one more on April 12th. I can't remember exactly the date, but you should all have announcements to that effect. So without further ado, we'll introduce our guest speaker, Dr. Sarah Hunt. Dr. Hunt is an Assistant Dean of Behavioral Health Sciences at UNLV School of Medicine and with the Department of Psychiatry and Behavioral Health, and also serves as the director of the UNLV Mental and Behavioral Health Coalition. She completed her doctorate in psychology at Utah State University. Dr. Hunt completed her pre-doctoral internship in Toronto, Canada. Her research and clinical interests have focused on individuals with chronic health concerns. Prior to starting her current position, Dr. Hunt worked in multidisciplinary healthcare system setting, providing assessments and therapy to individuals with obesity, diabetes, and sleep disorders. Her current work at UNLV Coalition is focused on improving mental and behavioral health workforce shortage in Nevada, with a focus on training students in an integrated approach to providing health care. Welcome, Dr. Hunt. Oh, there you are. And can we hear you?
Can you hear me?
We can hear you.
All right.
Thanks for being with us. Welcome.
My pleasure. Happy to be here tonight and be pleasantly distracted from other life things going on.
Yeah, there's some things going on, right? I've been walled up in my home all day and working from home, so y'all notice that my grading is almost caught up. Sarah and I worked together at UNLV, and after I left UNLV when I was at GBC, through a number of different projects. We've been great friends and allies for 5 years now, I guess.
Yeah, that's right.
Yeah, it's always been fun. So I'm really happy to welcome you tonight and look forward to your presentation for our students. Looks like there's 35 folks online. And then as Dr. Hunt gives her presentation, we'll take a few minutes here and there to take questions. Dr. Hunt, the floor is yours.
Okay, so tell me how I can get my presentation up here now.
Okay, so at the bottom of your screen, your window,
Yes.
There's a button called Share with an arrow. It's a green box with an arrow at the top.
Yeah.
You click that, and then you hit your screen, and you should take over there.
Okay, can you see that, my introduction slide?
Yep, it's got, I'm seeing what you're seeing here, that's taken over the full screen.
Okay, perfect. All right, good evening, everybody. So one of my kind of passion projects is to see the growth and development of integrated healthcare. So I'm going to kind of get into a little bit about what that means. It's a practice of medicine and mental health collaborating to provide care, kind of whole person care to patients. And it's something currently right now that we see practice mainly in the veterans, the VA system, as well as federally qualified healthcare centers, outpatient care centers. But tonight I'm hoping to, let's see if I can get my slides to advance here. I'm not sure if that did or not.
Looks like it went.
It did, okay.
Just use the arrow key. There we go.
Yeah.
Or the enter key, the space bar.
Hey, okay. Now does it say objectives?
Yep.
Okay. Sorry, everybody. This is new for me. So as we kind of spend our hour together, I just want to start by defining what I mean by when I talk about integrated healthcare, what the models of integrated healthcare look like, some of the benefits of why this might be a good idea in practice, and then describing the role of what a behavioral health consultant does in these type of medical settings. And you'll see I've got a picture of the spaceship Enterprise on there. And if we were in person, I would ask you why you, or what connections there are between integrated healthcare and Star Trek. And since I won't get an immediate response from you, I will share the answer with you. So when I think about integrated healthcare models, I think about it as not being the final frontier, but the next frontier. So hopefully some of you Trekkies out there kind of understand what that means. And we're also going where no man has gone before as mental health professionals. So historically, we have not practiced a lot in primary care settings. And just to be clear, when I talk about primary care settings, I'm talking about your family practitioner, your family medicine practitioner, your pediatricians, your internal medicine docs. A lot of women go to their OBGYN for primary care. So in those type of clinics, as mental health professionals, we have just not had a strong presence in there. But also, a lot of people point out to me on Star Trek, you know, they were kind of an integrated team working together. So I'll throw that in there as well. And so when we talk about defining what integrated healthcare means, this is a great kind of picture to represent how the definition has really grown from the roots of we have practiced mental health care separately, we've often practiced substance abuse care separately, and then primary care has also practiced separately. So from those three kind of roots, we're starting to intermingle and grow together. And it's taking on these different descriptions of what integrated healthcare means. And then this is just kind of more of a verbal description of what it means. So at the simplest level, integrated behavioral and physical health care occurs when a mental health specialist and a primary care provider work together to address the physical and behavioral health needs of their patients. And integration could look bidirectional. So that could mean myself as a psychologist, I start working in a primary care clinic, or what we are starting to see is a lot of traditional mental health outpatient centers are hiring primary care practitioners to come and work in their facilities to provide that medical care for patients. And here's just another fun visual representation of what that means. So by practicing healthcare, we're just rediscovering the next. So we're connecting behavioral health, which is often thought of our mind and the brain, to physical health, which is everything below our head. And so we're the neck, just bringing both of those pieces together to treat the whole person. And this table, hopefully it's not too difficult to read, but this is a representation of what different models of integrated care look like. And it kind of happens on somewhat of a spectrum. So at the one end, you have the level 1, minimal collaboration. So this table represents how well or how collaborative a primary care provider and a mental health provider are connecting. So at a level 1, they're going to look like they're in completely different offices, and maybe a primary care says to a patient, you know, I think you would benefit from some mental health treatment. You should consult your insurance and find a provider, or maybe they happen to know a therapist and give them that contact information, but there's not a lot of working together aside from that. And as you move across the columns, you'll see that the primary care provider and the mental health professional are working more collaboratively, more closely. They're starting to be in the same facility. So the middle columns there where they're co-located, that often looks like in a large hospital system or medical system where there's a primary care office on one level of the building and the behavioral health outpatient clinic is above them, and they refer back and forth. They probably share sometimes the same electronic health record. And as you go to the far level, level 6, then that's where primary care provider and a mental health provider are working in the same office space. They're meeting regularly or talking regularly with each other about the patient's care. And that may also look like a whole team approach. So there may be regular team meetings to talk about patients where the primary care provider is there, the mental health professional is there, the nurse is there, maybe even the psychiatrist, other personnel in that one clinic that are treating the patients.
Sarah, do you mind if we take a minute or two just to answer a couple questions before you go on?
Yes, please.
Okay, so those of you who have your hands up, I'm gonna go ahead and try the allow to talk button so you can ask your question. I see somebody has a hand up. And go ahead.
Yeah, I was just wondering, is the...
what's your name?
Oh, this is Bryce up in Elko.
Hi, Bryce.
I was just wondering, the code is going to be given at the end. My Wi-Fi is a little slow, so I joined a few seconds
Yes,
late.
I'll give the code at the end.
All right, thank you.
Anybody have a question related to the topic at hand before going on?
Although I do support giving the code at the end as well.
Go ahead, Brianne.
Yeah, I had a question about your the content of the presentation. Could we get a copy of that?
Oh yes, absolutely.
Okay, perfect.
Yes.
Thank you.
So when she, when Dr. Hunt emails it to me, I'll post it in your classes.
Okay, perfect. Thank you.
Any other questions related to the topic? Okay. Please continue, Dr. Hunt.
Okay, so again, that's what, there are varying models of what integration looks like depending on how physically co-located the mental health and the primary care providers are, how much they're sharing a shared electronic health record, and additional factors there. So I often use this slide to make the case for why we would want to consider integrated healthcare practice. So these are some statistics that are often used in supporting that. So actually, when we think about patients who are experiencing a mental health issue or social emotional issue, they're oftentimes going to go to their primary care provider first, or parents will take their child to the pediatrician first before they're going to seek out a mental health professional. And there's a lot of good reasons for that. And so we understand that about 30 to 80% of primary care visits stem from a behavioral health issue or mental health issue. But the other thing on kind of the other side of the spectrum, those with serious mental illness, we know on average have a shorter life expectancy than the general population. And oftentimes those with serious mental illness have that shorter life expectancy because they also have a comorbid health condition, like a cardiovascular issue, a pulmonary issue, or infectious diseases. And if you combine kind of that really chronic health condition with a really chronic serious mental illness, we often see that those type of patients aren't presenting regularly for medical care, for primary care. A lot of times it has to do with kind of social factors. It often has to do with their mental health and their mental illness symptoms. And so we know that there's a disconnect there. We have this group of folks that have a really serious chronic mental illness and a medical condition. So how do we best treat those? And prevalence, we know that there's a connection between depression and diabetes, especially type 2 diabetes. But the most stunning statistic, I think, is the one on the bottom there, that where research is showing us that that individuals who have completed suicide have contact or had contact with a primary care provider or some sort of medical specialist in the previous 30 days. And that rate of about 50% of individuals, that rate actually goes up higher to 65, 70% in our elderly population, where they know they had a recent contact with a primary care provider. But only 15% would have seen a mental health specialist.
Mm-hmm.
So again, if we're saying that a lot of this is presenting in primary care, then it sure makes a lot of sense that mental health professionals should be in those clinics practicing with their medical colleagues.
Yeah, and another thing is I'm guessing that, and I was at the doctor recently, they don't screen for serious mental illness. It could be a simple question is, a suicide questionnaire that could alert the doctor that you probably need mental health care as well.
Yes, and that's a really good point. Probably a lot of you that have gone to your primary care provider recently, over the past 5 years or so, we're starting to see more screeners used, where when we check in for our appointment, especially if we haven't been there in a while, they give us all the new forms to fill out, and you'll see questions there asking about our substance use, smoking, and hopefully there are questions that are asking us about our mood. So have we felt a certain way, or how much have we felt that way in the past 2 weeks or 30 days? And often a lot of primary care providers are using the PHQ-9 assessment. I think that's the Patient Health Questionnaire 9. And the 9th question on that, it's a depression screener, but the 9th question on that gets at, have you had feelings of harming yourself, thoughts of suicide? And so we're starting to see that roll out more and more in primary care. The problem is, though, if our primary care folks are asking that, then who's following up in the office? And that is pretty varied on who collects that screener from the patient, looks at the score, and then communicates that to the primary care doc. But just some additional benefits of integrated care models. So again, going back to that screening point, if as a trained mental health professional, I'm working in that clinic, I have a lot of experience and knowledge of screeners that we could be giving out for depression, for anxiety, for trauma, and substance use. So our primary care colleagues don't get a lot of training in that in medical school or nursing school, and that's one benefit to that. There's a lot of comorbid depression with health conditions that if we're there working in tandem with our primary care colleagues, that we can be involved in. We can also then increase the access to immediate mental health care. So again, if you think about primary care providers, if they want to refer a patient for therapy, that person currently, that patient has to go to another location. And we know that the kind of the success rates of that person following up with the therapy referral is low. So if I'm there on site working with a primary care doc, then I can start working with that patient immediately. It also reduces the stigma. So we don't think twice about going to our physicians or primary care providers. That's just kind of a normal socialized thing to do. And so if mental health is in that clinic, then who's going to know who you're seeing at the medical center, at the family care center? Cost savings, so we know, again, if we're treating the whole person, their health condition with their mental health issue, we're going to see a lot of reduction in hospitalizations, emergency room visits. Their care is going to improve. Increase patients for primary care. So if we're kind of offloading the mental health issues from the primary care docs, that frees up some more time for them to see additional primary care patients. And also research on this topic shows that patients and providers are both experiencing a lot of benefits and positive things from having that integrated model. And now I want to kind of shift into, so what is it that a primary or a mental health provider is going to do? What does that look like when they're practicing in a primary care clinic? And so I want to talk about the behavioral health consultant role. So when I refer to that, a behavioral health consultant can be any licensed mental health professional. So it could be a psychologist, it could be a licensed clinical social worker, it could be an addictions counselor, a marriage and family therapist, a professional counselor, but anybody that's kind of licensed as a mental health professional, we give them the title of behavioral health consultant when we're talking about integrated care. And this person is going to be a generalist. So they're going to be prepared to see, if you think about family medicine, a lot of the family care providers see everybody in the family, all ages. So this person's going to be trained and prepared to work with patients of all ages and different behavioral health or mental health issues. They're going to be seeing people on a same-day basis. So if we think about what traditional outpatient mental health care looks like, those mental health therapists and professionals block out their schedule for the day with 45 to 50-minute visits. You're scheduling the patient ahead for next week or in 2 weeks. In this type of practice in integrated care, the behavioral health consultant is going to be available to do really quick same-day consults. Their primary care colleague may pull them into an exam room to meet with a new patient and explain why they would like the patient to start meeting with the behavioral health consultant. And we'll talk a little bit later about what that type of visit would look like. The behavioral health consultant is also going to be viewed as just a member of the team and can help the team on many different ways. And the team can be the nursing staff, the front office staff. Sometimes clinics also have dietitians working with them, and so they would all be a part of that team. And they're going to help meet patient needs through individual sessions with them, through doing group visits or group therapy in the clinic, providing resources outside of the clinic to patients. So I kind of think of them as a utility player. And they're going to be able to see a lot of patients in one day because, again, they're going to do really quick, brief interventions and interactions with patients. They're also going to be there to provide a lot of education to the other members of the team. So again, primary care docs or physicians, nurse practitioners get a certain amount of training on mental and behavioral health issues. But why wouldn't you have somebody that is their sole expertise working along in your clinic and helping you understand the issues that your patients are presenting with? And we can also help develop pathways of care. So if we know that there's a strong relationship between type 2 diabetes and depression, so a behavioral health consultant could say, okay, for all of our type 2 diabetes patients, here's a pathway of care, or how we, what the kind of menu of interventions that we're going to present to that patient, not only from the medical side, but the mental health side. And this slide just talks a little bit more about the role that the behavioral health consultant would have. We're really there to help the primary care provider manage their patient load and improve overall function of the clinic and function of the patient. But to do that, we need to have a fair amount of understanding about medical conditions. So we kind of have to learn their language as well as teaching them about our language. I often think about this in the terms of we're like a foreign exchange student. We're going to a new country where maybe we've got some knowledge of their language, their customs, but we're also there to share our knowledge and our customs as well. We're going to be there to support case management and, again, referrals for the team, support the providers with medication management and education. So if you think about using a type 2 diabetes patient again, they're newly diagnosed and now they have to start taking a medication or injection that they've never had to do before. There can be a lot of stress and kind of emotional response to that. So the behavioral health consultant can help work with the patient on that to help improve their compliance with their treatment. Again, we're going to be there to do consultations on patient care, and our interactions with patients are going to be very brief and focused. And again, a lot of education to the medical team, not only on mental health issues, but cultural awareness, social determinants of health. Okay, so since I've described a little bit about what the behavioral health consultant is there to do, I wanted to go in a little bit more in depth about what it actually looks like in practice. So if you think about, again, a psychologist or licensed clinical social worker or any type of counselor working in this setting, it's going to look very different than traditional mental health outpatient care. So whereas in outpatient care, the therapist has their own office, they have somebody that is sitting out front to check patients in. We will have probably no office space that is our own, because we're going to be moving from exam room to meet with patients. Maybe there will be a small office space that if we needed to do kind of a half-hour visit with the patient, or if we want to schedule them to come back for a 30 to 45-minute traditional therapy session, then we've got some space that we can do that in. But we're going to be very flexible in location and how we work. And we're just going to be right there in the chaos. If you think about kind of what your primary care clinics look like on a busy day, there's a lot of people running around, especially if it's a large clinic. And typically, as therapists in traditional mental health outpatient clinics, when we go into session, we're in session with our patients, and we tend to not be disturbed. We don't want to be disturbed. We don't want to disrupt that kind of therapy, the interventions that we're doing. But in this type of setting, we do want to be disturbed. We want to be kind of pulled into exam rooms to meet with patients, especially new patients that our primary care colleagues feel like could use some mental health or behavioral health support. And to do that will create a lot of success in, again, connecting those patients to mental health evaluations and interventions that they will need. And so we will have to do some education to our primary care colleagues and healthcare staff that we want to be interrupted. That's okay. And so we can have our appointments as a behavioral health consultant. They're going to look quite varied in this type of setting. So we could have scheduled follow-ups. So maybe I did a quick consult with this patient last week and I wanted them to come back and meet with me. So we've got it registered on the books that this patient is going to come back and see me for 30 minutes or 45 minutes the next week. A warm handoff is when our primary care physician colleague identifies that the patient needs some mental and behavioral health support. They're going to go down the hall, grab us, bring us into the room, and do the warm handoff to the patient, where they're going to introduce us as, this is Sarah Hunt. She's our behavioral health consultant. I would like her to talk with you about your increased depression, your problems with sleeping, whatever it might be. And same days follow-ups as well, or appointments. So maybe you're working in a clinic with a lot of different primary care providers, and you're not able to attend you've been asked to do 2 consultations, but you can only go to 1 at the time. They may have the second consult say, the behavioral health consultant is not available at this time, but can you come back in 30 minutes or later today at 2 o'clock, because I've got some time built in for same day appointments. And again, we can do group therapy in this type of setting as well. And thinking about how we document our interactions with patients. So in traditional mental health outpatient therapy, we do a lot of dictation or writing of our notes. If we've got a 45 to 50-minute therapy session, ideally, when that session is done and we've got 10 or 15 minutes left in the hour, we want to do our notes immediately right there where we're dictating the therapy note. But in primary care, you're going to be doing it on the fly. So if you think about when you go to see your primary care doc, there's computers now in every exam room, and they're typing in the notes as we're going. Well, that's the same way for a behavioral health consultant, and that's a skill set that we have to learn along the way. And our notes are going to look briefer than what a traditional outpatient therapy note would look like. And this may be a little bit difficult to see, but this would be kind of an example of what a schedule would look like for a behavioral health consultant in primary care. So you see that on this particular day at 7:30 in the morning, they start with a team huddle. So that means the primary care doc, the nursing staff, the behavioral health consultants are all going to get together. It's often a quick time to kind of look at the appointments coming in that day. What shared patients do we have coming in? Who's going to be addressing what? And then throughout the day, this behavioral health consultant has got time built in to call patients for follow-up, just check in to see how they're doing. Some traditional face-to-face follow-up appointments. But along the way, you see they're also kind of getting pulled to do consultations. And so this is what it looks like. It's not just a schedule of I've got 6 or 7 patients scheduled for my day at 45 to 50-minute intervals for therapy. This looks quite different. So if you think about kind of what you conceptualize a therapy session looking like, this is how we would do something like that in 30 minutes or less. And I have the NOID there on the screen, and I'm curious, Oscar, do you remember the NOID or know who the NOID is?
Yeah, the Noid's wasn't he from Domino's Pizza?
Yes, exactly.
Yes, that's right.
Okay, so back in the 80s, which I'm not completely sure many of you were around for yet, but there was a commercial advertising campaign from Domino's promoting that they would deliver their pizza to you in 30 minutes or less. And they came up with this cartoon character called the Noid, who was going to do everything possible to disrupt that 30 minutes or less. So
avoid the Noid.
Avoid the Noid, that's right. That was their campaign slogan. So how are we going to do this in 30 minutes or less? So for a behavioral health consultant, it looks like the first 15 to 20 minutes, you're going to do, the bulk of your time is just going to be assessing what the issue is with the patient. Why does the primary care provider want you to see this patient? So you're going to start by spending a couple of minutes introducing yourself and what it means to have a behavioral health consultant, what your role there in the clinic is. Then you're going to spend some time kind of understanding and identifying the reason for the consultation with the patient. So doctor, who told me that you're having more difficulties with sleeping? Can you tell me more about that? And then we do what we call a functional assessment of the problem. So if the issue is difficulty with sleeping, then we're going to ask some very specific questions to get at what is the problem with sleeping. Is it you're having problems falling asleep, or is it that you're waking up in the night, having difficulty going to sleep? Is it every night? Is it how long? If you're waking up in the middle of the night, how long does that last for? So all of those kind of very specific questions to pinpoint what the issue is. And then we're going to finish that assessment with kind of an understanding of the problems, or summarization. So from what we've talked about, my understanding of your problems with sleep is blah, 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 blah. And that gives the opportunity for the patient to clarify things that we might have misunderstood or we got wrong. Because again, we want to make this really targeted to what they want the help for, or why they're coming to see us. So after you've done that assessment, we would move into what we call the advise and agree. So we refer to this whole 30 minutes as the 5A system. So advise and agree is, here's what now I'm going to give you some feedback on that issue. So if you're saying your difficulty is falling asleep, I'm going to educate you on sleep hygiene. We're going to talk about tips and strategies that help promote good sleep and falling asleep. We're going to also talk about any possible options for resources or interventions. So if there's something that from the community, outside the community, that would best support the patient's needs or issues, we'll review that, we'll talk about that, and we'll kind of present so I can help you with your problems with sleeping if we meet for the next couple of weeks, 3 weeks, 4 weeks, whatever. I'll have you come in once a week and we'll meet for this amount of time. And so we'll present that to the patient and get their feedback on if that would work for them, if that helps, again, meet the need that they're there for. And once we've kind of come to that understanding, then we move into the final 5 to 10 minutes of that half hour, where we're going to assist and arrange. So we're going to review, again, everything we talked about. We're going to provide some, we're going to talk about the interventions that we're going to work on. So again, if this is a person that's having problems with sleep, we're going to talk about sleep hygiene, what are good steps to take to promote sleep, and we're going to talk about how they could start working on that until we see each other. So that's the intervention. And then we're going to finish by making sure we've got a plan for follow-up. So as we talked about, I'll have you come back in next Tuesday at 3, and we'll schedule that on the way out. Any questions right now, or do you want me to keep going? I can't hear you, Oscar, if you're saying anything.
Sorry. Yes, let's take a few minutes for questions. If you'd like to ask a question, go ahead and put it. Let's see. We've got Amy has got her hand up. I'm going to go ahead and allow her to talk. Go ahead, Amy. Go ahead, Amy. If we can't hear you, so maybe you can type your question into the chat window. That'd probably be better if anybody has a question, just to type it into the chat window right now. Kim had a question. And she was referring to the levels of integration.
Yeah.
The roles and cultures blur, excuse me, the roles and cultures blur or bend. Is there any drawbacks? I'm not sure if I understand the question exactly.
Sorry, was it the models of integrated care?
Yeah, that slide right there.
Okay.
The roles and cultures blur or bend. Is there any drawback?
Yeah, so that's a good question. So hopefully I'm understanding your question right. So if we think about, if we're going in as mental health professionals, um, our role in culture does look quite different sometimes than medicine, although there's some overlap. One example where that can play out as kind of contrasting is our code of ethics. So this maybe gets in the weeds a little bit, but I think it's a good example. So for example, in medicine, physicians feel comfortable treating their colleagues for certain things, or a colleague will, or they'll see multiple members of a family. In mental health, we tend to have kind of stronger boundaries about that. So we're not going to provide therapy to our colleagues. We don't want those dual relationships. And we also tend to see just one member of a family. And again, that kind of goes into confidentiality issues and conflict roles. So when you talk about integrated care, a lot of what helps it be successful is clear understanding of what every role is of the healthcare team, what member is going to do that, especially if you think about case management, and maybe there is a nurse case manager, and maybe there's a licensed clinical social worker on the team. They could have a lot of overlap in their roles, so everybody needs to be kind of clear and defined on what that means. Hopefully that was helpful and kind of answered your question.
Yeah, thank you. So we've got another question here. What policies would be in place to ensure that not only the primary care provider follows through with mental health services, or others who work in the healthcare fields, nurses, MAs, anyone interacting with the patient? I think the question is speaking to, are other providers able to refer for follow-up care to mental health professionals?
Yes, they can. And that's kind of the current default system of our healthcare system right now. If you think about primary care, because we don't have a lot of mental health professionals working in those settings, if we've got, I'll say this, a lot of primary care providers, whether they're physicians or nurse practitioners, some do have a higher comfort level with treating mental illness and mental health issues, and some have a less comfortable level with that. But either way, there's going to be a certain section, a portion of their patients that they're just not going to have the skill set to do. And then that's when referrals happen. Now, how successful those referrals are to mental health goes back to our models of care and also the relationships that they've built with mental health professionals in the community if they're not in their clinic. Hopefully that was.
Yeah, I think that sounds pretty clear. Thank you. I have another question. How many mental health providers can there be in one health center?
Yeah, that's a good question. And there's probably some good staffing ratios out there. So I know that, and honestly, it really depends on the workforce that we have for mental health. So we have a significant shortage of mental health professionals right now in Nevada. So it could look like a larger primary care practice may have 5 to 10 docs or physicians, and maybe, if lucky, one behavioral health consultant. And then things get really stretched. And so there needs to be some clear understanding about what their role is. But in other centers that are maybe better funded, they may have as well 5 to 10 behavioral health consultants to match the number of providers. And then in those type of situations, you see the behavioral health consultant is kind of assigned to 1 or 2 physicians. And so if you've got, 5 behavioral health consultants, they're assigned to 2 of the 10, each of them is assigned to 2 of the 10 physicians. But again, it really depends on the clinic, the financial capabilities of the clinic as well.
And this is something the insurance company likes to see because they see the care is more effective when they integrate this care. So they're not coming back for very expensive medical procedures or things are getting worse because they're heading off these issues early on, hopefully, and they're
Yes,
consistent with the
exactly.
care. Okay, well, let's allow Sarah to continue, and then we'll take a few questions in a little bit. Got about 20 minutes left. Just want to, just so you know, on time.
That's perfect. Okay, so we've talked about kind of what that first initial I'll say up to 30-minute contact looks like with a patient. And so I wanted to talk a little bit more about what are the kind of specific interventions that a behavioral health consultant would be doing with patients in this type of setting. And a lot of them are the same we would do in traditional outpatient mental health. We're just going to adapt them to the setting, to the time that we have, and we're going to hopefully use them in the best evidence-based practice that fits the concern of the patient. So sometimes it will look like one of and this isn't the exhaustive list of interventions, but these are the most commonly ones that we use in integrated healthcare. So behavioral activation, goal setting. So behavioral activation we use oftentimes a lot with patients that are presenting with mild to moderate depression. So if you think about depression, sometimes that looks like withdrawing, doing the things that we enjoy less. We're not socially engaged anymore. We've stopped doing maybe our physical activity routine. And so we want to start activating the patient to start doing things again, whatever that looks like. Goal setting. I use this a lot with patients that I was working with on weight management. So if we look at making one change in their nutrition routine, their diet routine, maybe it's I want to cut down on the amount of donuts I'm eating in a week. Well, then let's set that as the goal and we'll revisit that next week. Relaxation training, that applies a lot to kind of stress, anxiety, also touching on trauma work as well. So that could be looking at deep breathing, introducing patients to relaxation apps. Hopefully everybody has a relaxation app on their phone. Psychoeducation, so doing education on, so it sounds like you've got insomnia. This is what insomnia looks like. It could be teaching the patients about what depression looks like. So you've got a diagnosis of depression. So that's what this means. Parent management training. So this will play out in pediatrics a lot. So working with parents on issues around tantruming, non-compliance in their children, motivational interviewing. So this we apply to patients that are thinking about or would benefit from changing something about their behavioral patterns or their health patterns. So we apply that a lot, thinking about reducing the use of alcohol, reducing the use of substances. So kind of tapping into the personal motivation of that patient to change. Problem solving, that could look a lot like related to more kind of social issues or social determinants of health. So I'm not able to fill my prescription because I've lost my job, I don't have insurance. And self-monitoring, so that one I would use a lot in going back to sleep issues. So you're saying that you're having problems with sleep. I might give them a log to kind of track what their sleep habits look like for a week and have them bring that back in. And this is where, in practice, it's going to be really beneficial for the behavioral health consultant to have a lot of handouts for all of these different things. Because if we've got kind of a limited time with a patient, but we want them to leave with something, they feel like they've got something to start with or something that will help until we can see them again, that's where handouts are excellent. So we'll have handouts on community resources, on relaxation strategies, again, sleep hygiene, goal setting, those self-monitoring logs like I talked about, or child behavior logs. So if the issue is, when I was working with pediatricians, they like to send me all the cases of tantruming kids. And so we would talk about with the parents who at this point, if they're so distressed by it, they just feel like the tantrums are happening anytime, any reason. Well, let's start tracking it so we can identify the pattern of what kind of triggers these tantrums. Behavioral activation, again, things to get people to start doing things. And prescription pads, I like to say, aren't just for our medical colleagues to use. We can kind of come up with our own prescription pad. I mean, certainly nothing that is needs to be approved by the pharmacy board, but basically it's just something to write down to send home with the patient that this is what you're going to work on, or this is what we talked about working on for the week. So they've got something in their hands, a visual representation of what you talked about that you can take home, or that they can take home. So
Yep.
I think that's actually the end of my presentation.
Oh,
so
okay.
that maybe worked out well for timing.
Okay, great. Yeah, we have a few minutes for about 10 minutes for questions. So Amy's asking, what, when constantly being mobile, what are some of the best practices we can use to maintain confidentiality? That's a big question.
Oh, see, I'm sorry, you cut out a little bit. Could you say
sorry.
that one again?
You know, when being mobile, what are the best practices we can use to maintain confidentiality?
Yeah, that's a good question. Because again, if you think about what your experience, your own experience has been in primary care clinics, or when you go to see your doctor, we often hear a lot of things that we don't want to hear. And so, and that can get a little loose in medicine, to be honest with you all. And so for primary care provider, or for behavioral health consultants, sometimes we talk about doing curbside consultations or hallway consultations where a primary care doc might grab us in the hallway and say, hey, really quickly, I've got this patient, blah, 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 blah. So as behavioral health consultants, we want to be kind of mindful of that, of the environment, who's around, what's happening. And maybe we could say, great, can we step into this office, or can we go here and talk about it quickly? And so I think we're very aware of surroundings when we're talking about patients, how we're communicating with patients. So it's not shared with the whole clinic. But to be honest, you know, some of these exam room walls are very thin, as you probably know. Mm-hmm. So we do the best with what we can, being very mindful of the importance of confidentiality.
I'll share my experience. I was recently in the hospital for a procedure, and it was a very minor procedure, and I'm laying on the table or whatever, and the door's open, and the nurse says, "It's okay, nobody's in the hall." And I was like, okay, whatever. You know, like, what am I supposed to do at this point? I just kind of roll with it. But I was thinking that would be, you know, a violation of my privacy and while receiving care. But.
Yes, so I would often try to use some humor and remind colleagues that, you know, the nurse's station, there's no invisible soundproof booth around it. So all those conversations, right, everybody can hear.
Yeah, they get really used to just talking to their coworkers.
Yes.
We have another question from Amelia. Integrated care agencies usually have many clinics with thousands of clients. How can a behavioral health consultant manage their high client caseload while still monitoring patient progress?
Yeah, so this, I would say, you know, as you've listened to the presentation, you might gather that this is actually kind of a specialty form of mental health care and behavioral health care. And so this type of work isn't for every behavioral health consultant, because you really have to go in with the mindset that I've got to be very flexible. I've got to be able to work efficiently and very focused to be able to maximize the most of my time, But certainly in a busy clinic day, you're not going to be able to do everything, but hopefully you've got your schedule, you've got your healthcare team trained on what it is that you're capable to do, not able to do. You've got those built-in follow-up appointments, and you're just going to be able to do the best that you can. If you're the only behavioral health consultant, then it may look like, and you're in a very busy practice, it may look like I'm here, but I have to focus my interventions on specific issues. So some clinics, they have the behavioral health consultant. If they know they've got a high load of type 2 diabetes patients, then that's what they use the behavioral health consultant for.
Thank you, Sarah. There's a question about handouts. I'm not sure if they mean your presentation or information with this type of topic in it. I need clarification on that question. Any other questions for Sarah? I know if you had your hand up, and I'm kind of encouraging you to go into the chat window because not everyone, for some reason, we can't hear them. Okay, I don't see any questions. We'll go ahead and giving respect to Sarah's time, and I asked her to be here for an hour, and I want to thank you very much for being here.
You're welcome. Can I just put one pitch in for, I hope you all consider a career in mental health. Again, we desperately need the providers. I hope you all continue your education, move into those different professions that would allow you to work in a variety of mental health care, and that you start to feel some sort of passion for it. It's a great area to work in. And again, I think we're making exciting inroads into being in these medical settings where we should be. We should have always been there.
Yeah, and maybe it's just the evolution of the discipline. I do, because we have a few minutes, if you don't mind asking you to talk a little bit about your work with the Behavioral Health Coalition. I know that's a passion project for you, and you've done tremendous work in that area.
Yeah, so thank you. So at UNLV, we started the coalition, which is faculty members from all of our different mental health training programs at UNLV, and we meet regularly to talk about the workforce shortage. So how can we recruit more students into mental health training programs? And then on the other end, after they've graduated and they're ready to get licensed or certified, whatever, how do we keep them in Nevada to start meeting that need? So the stat I use right now, about 95% of Nevadans reside in a mental health professional shortage area. And that includes all of Clark County and all of the rural counties. So, and that's across disciplines. We just don't have enough of anything.
Yeah. And because I work with Sarah in these projects, and she really drives the movement to organize the mental health fields, or the interdisciplinary fields, and works with the boards and works on your behalf, whether you know it or not, when you're going to become a mental health professional, making it easier to get licensed, making it easier for other professionals from outside the state to get licensed in our state, which is a big hang up, providing a kind of a seamless pathway from education to professional licensure. And she's done an incredible job. Of course, there's so much work to be done, but I just wanted to I guess express my gratitude for that, and think about how much it helps our education programs and our professional practices. So
thank you. I appreciate that. You're very welcome.
Yeah, I hope you're seeing all the thank yous that are coming in through the chat window from all the students. Everyone has got some really great appreciation for your time here. And
I wish I could. I am just not technology blessed, so
okay, I'll take over. I'll take over, and hopefully you can see my screen. Can you guys see my screen now?
Yeah, I can see
Yeah,
it.
and so here are all the thank yous from all these folks. So it looks like we've got 42 attendants, and hopefully everyone had a great time. I really enjoyed your presentation, and there's nobody better in Nevada that I know of to provide this kind of information. I know Sarah's taught graduate courses specifically related to this topic, and she's the expert, and I'm sure she's doing the same kind of work at the medical school in some capacity.
I am. I'm trying to teach now the future doctors why we're important.
Yeah.
So, and thank you for the appreciation. I'm always happy to get feedback. And you can share my email contact with everybody too. So if you're thinking about, again, going into one of our mental health professions, feel free to reach out to me. I want to figure out a way we can keep you in the state. So.
Yeah. Right. Thank you so much, Sarah, for your time.
Yes, I hope everybody has a good night, and everybody just be well and practice good social distancing and hand washing.
Okay, folks, so we're going to stay on the call for another 30 minutes and talk about some things related to our program, but we'll go ahead and let our guests go. So thanks, Sarah. Thanks for joining us.
You're welcome. Bye.
You'll have to sign off. There you go. Okay. So thanks for all for being so gracious to Dr. Hunt. She's a really great professional and just a really all-around nice human being. She's married to a guitar player, and she had told me on a work trip at a conference in DC how they met. She showed up to a gig of his and just kind of fell in love with him. I'll never forget that story. So aside from that, I wanted to thank you guys all for being here. If there's any other questions regarding integrated care that I can answer, I'd be glad to. I can tell you I worked in acute psychiatric at a behavioral health hospital, and I got baptized by fire. I was a trained mental health counselor. However, I had not worked in the medical field. So when I was working in the hospital setting, even though it was a behavioral health hospital, we had physicians, nurses, nutritionists, all kinds of other complementary health professionals working together. And we would all gather into a treatment team before we would assess and provide recommendations for the treatment of the patient. So I had to get really familiar with the medical terminology, with the different roles that people had played. And I had been trained kind of in isolation in just the mental health field. So I encourage anybody who's interested in working in integrated care through your internship experiences that we have in the associates program, to go into medical areas or places that have integrated care, hospital settings, mental health agencies that have medical treatment providers there also. It's becoming the new model. It's more efficient. There's a lot of cost savings. There's a more accurate diagnosis and referrals, because what a lot of times happens is when you're trained in a specific discipline, you just see the problems within your discipline. So you're a doctor, you see medical problems. You're a mental health professional, you see mental health problems, and we tend to ignore the other things that lie outside our scope because there's nothing we can do for them. It's like if you go to a plumber, he's not, he might not look at the electrical problems in your home because he's not trained to repair those issues or identify them. So Amelia is saying, I work in integrated care and I have 11 facilities and 15,000 patients. Those are all assigned to you, Amelia. I don't know how that would be even possible to manage. It sounds like those are the, okay. Oh, she has 150 patients. Okay. Yeah, but that's still a tremendous caseload. And so because we don't have enough providers, and also we have to work at getting higher reimbursement rates. So it's more it's more realistic for businesses to provide these types of integrated services. And I think Dr. Hunt did speak to this issue that you have to really focus. And let me just ask you, Amelia, I know you're practicing in Arizona. So how do you manage that high caseload? Do you focus on specific things and kind of not get in too deep with some of the issues, or what is your strategy? Oh, hopefully you're typing that out. Any other questions? I'm sorry, I know if you had your hands up and I I put them down because I wasn't able to get everyone in. Okay, so Amelia's response, relying on clinical team, focus on independent living skills and housing specifically. So yeah, those are some very specific tasks that you're working with in terms of active daily living. Yeah, a lot of communication and reading client notes. I wanted to speak a little bit about what's going on since I have you all here in a group. The college has made some significant changes. Hopefully you're getting those emails from the president's office, and I have suspended all practicum service to human services agencies for our practicum students. We don't have that many students, and there are about 14 in practicum between the bachelor's and the associate program. And I took the decision to suspend practicum. They were going to extend it till after spring break, and I thought, why take a risk? Let's go ahead and get everybody out of their sites as soon as possible. And so I'll probably be developing some different activities and assignments to fulfill those practicum hours that are being lost. You won't be penalized for that. This is not a regular situation, so we can't adhere to regular policies and rules. So I've been given authority to be flexible in how I meet the needs of those students. So just so you know, we are doing what we can. Luckily, our program is 100% online, and that gives us, we're kind of ahead of the curve in that sense. A lot of universities and colleges are having to take their in-person courses or hybrid courses and put them exclusively online, which is a big task for them, but that's our way of doing business in human services. Another thing I wanted to bring up is that online, I've lost my train of thought. I had it, I forgot. Maybe it'll come back to me in a minute. Any other questions or comments? This was another great symposium. I just love the special guests we have here. And I'll tell you, the way that I obtain guest speakers for the Human Services program is through my professional relationships and networks that I developed over the years in private practice, working in behavioral health agencies, working for the hospital, working as an educator in Nevada. And that's one of the great things about the business. And, a lot of these folks, they make a lot of money and their time is very valuable, but every time I ask, everyone is very willing to give their time to students because they're really passionate about the work they do. And that's one thing I want to remind you is that in this work, in this field that you are just in the beginning stages of in terms of your education, you meet incredible people with hearts of gold, and they really have a passion for the work, have a tremendous amount of compassion for helping others and improving our communities. And that's why they do it, because it's not easy work, but it's worth it. The other thing that I wanted to mention is that just in your human services program, you have more training in mental health and in substance abuse than licensed doctors, licensed nurses, most medical professionals, unless they specialize in addiction. Like psychiatry would be an exception to that, or a specific mental health nurse, or where they have specific training. But just in the associates program alone, you'll have more training and education in mental health and substance abuse and identifying those things. And this is, I've developed your curriculum to really raise the bar. I would tell you that some of your coursework, I wasn't introduced to that stuff until I was in my master's program. But I think it's so important to introduce to early on, and then you'll be reintroduced at a higher level when you go through the bachelor's and then through your master's and then on to PhD. So we do the circular learning where you're picking up areas and you're getting deeper and deeper the higher levels you go. But I know you'll be well trained and educated when you go into the field. And that's really why I did it, because it wasn't about, trying to brag about how rigorous our program is or how tough some of the curriculum is. It's about thinking, what do they need to know when they leave here with an associate's? And I decided those were some of the some of the areas that were missing links in the education to professional practice, even at the associate's level. And I got a little shout out from Shayna. Thank you for setting this up. Excited to see who our guest is for the next one. Yeah, I'm still working on that. It might be me. Everyone's kind of in overtime mode right now, so I've been having a little bit of trouble getting some of the guest speakers. But we'll have something, as always, great planned for you guys. I see another person's hand up. What happened to that? Yeah, I'll go ahead and see if you can talk there. Hello. It doesn't seem that I can unmute you. There we go. Let's try that. Nope. There we go.
Can you hear me now?
Go ahead.
So I live in Winnemucca, and we don't have very many places to do practicum hours.
Uh-huh.
Is there a way that I can contact somebody here to do that
You know, I had this question come up before, and
afterward?
yeah,
After
well, you can.
the whole coronavirus is over.
Yeah, so once we get back into it, practicum is suspended indefinitely. That doesn't mean forever. That means we don't know when it will be over. So my hope is that fall will start up again. We don't teach practicum over the summer, but there are some resources that I can help you utilize. One of those, SAMHSA has a treatment provider on their website, and here I can just show you really quickly. We have time. Let's share my screen here. So this is because I actually did I did training to medical professionals for this. So it's called the treatment locator. So I'm sorry, who am I speaking to?
Leanne.
Leanne, what's your zip code, Leanne?
I don't remember the zip code for Winnemucca.
Okay, Winnemucca.
Nevada.
There we go. What do you don't write letters, or what's going on?
No, I send emails.
Okay, so
with all the technology in the world.
in this fine treatment.samhsa.gov locator, I went ahead and typed that in, and so what I've done is it shows the location, and now it's showing me agencies within the mental health field, and there's different. You can add different types of human services agencies in this box here, and then it comes up with a bunch of different areas that you can work in. Now, some of these might not be that close to you. This one looks like it's in Oakland, California. So when you're doing,
like I said, it's a small town, so
yeah, when you want
to
do the filter, and then we can do distance from low to high. There's different ways you can find places, and you might just not know that they exist. I'm not sure what happened here, but let's try this again. Distance, let's do 50 miles, so it looks like this doctor is the only place. Now that might be in a place you can work. I know I've had some folks work at a doctor's offices. We're going out to 100 miles here. And so Carlin Community Health Center. Now, it doesn't have to be, it might not be ideal, but there's nothing I can do about where you live. So we can get creative. It doesn't have to be a substance abuse, like let's say agency or a mental health clinic. It could be working in a school that has a school counselor that's willing to mentor our practicum students. I know a number of my students have worked in schools, or you can go to your local hospital and say, do you have any behavioral health or mental health programs, anybody I can shadow? And in the 4 years I've been at Great Basin. And the 5 years I was at UNLV, I've never had anybody tell me, I asked them and they said no to my practicum. First, because they want to help you. Most of these professionals went to their practicum. They know how challenging it can be, and they're interested in kind of giving back. So most of the practicum experiences have been good. Sometimes we have some not so good experiences. We try to mediate the best we can. So that's one way to do it. But
I'll try to contact the school counselor at Grass Valley and see what she says.
yeah, keep your mind open, and and of course you can always talk to me. We can brainstorm. I want you guys to feel supported. I've sent out messages to contact me. Some of you are really good at communicating. Other times I feel like maybe you guys are busy, and that's okay too. I just want you to know that I'm here and available, and that you are supported, and nobody feels like they're alone. Because if they feel that way, it's not reality. It's the way, because I'm here. You guys call me usually during business hours. I answer my phone right away. Or if you leave me a message, I try to get back to you right away. I try to be good about returning emails and messages through Canvas. This is an extraordinary time, but at the same time, hopefully we can still provide the high quality education you come to expect from our program. It's still a great school. It's still a great program. We have the best students, I can't tell you. And I've taught at many places. I've taught at UNR, I've taught at UNLV, I taught at Nevada State College, I've taught at Community College of Southern Nevada. And I will tell you, and I'm not saying this to stroke your ego or mine, the level of work that you guys submit is very high quality. And I don't know what it is about you guys, but it's amazing. And I'm very honored and proud of the students that we turn out at Great Basin. So, we've got some comments here. That website could be helpful to find ideas for practicum sites. Yeah, wherever you live. Some people don't live in the state. I'm going to go ahead and take you off there. DeVita Dialysis Center is open in Winnemucca. They have social workers for patients, so you'll be able to look there. Great. Yeah, so as we're sharing information, we have solutions to problems here. My mother works for Sonoma Elementary as a counselor. I may be able to contact her with my mom. Great. Share information there. I'll be able to use the same practicum site for next practicum course. Tiffany is asking. Yes, we do allow that. You don't have to use the same practicum site if you'd like to choose another one. If you decide, well, I had a good experience at this practicum site, or I didn't like it, or it wasn't giving me everything, and maybe I'm more interested in substance abuse, or I'm more interested in eating disorders, and you can find a site that kind of fits. So we have a limited amount of sites that we have affiliation agreements, and that means that the college has a signed document that allows us to send students there, and we have this agreement in place. It's a legal document. It has to be signed before you start your practicum. If you find a site and we don't have an affiliation agreement, that's okay. All you do is present yourself, ask if they'd like to provide an experience for practicum students, and then you let us know. You call the department, and with the contact information, and Winnie will set up that affiliation agreement. She's our admin assistant, or anybody in that office will set that up, and that's her role and responsibility. Used to be mine. I wasn't very good at it, so they took it away from me, which is probably good because I'm not the paperwork Nazi that I should be, but I have a different skill set. So luckily, Winnie's an outstanding assistant for the department, and she really gets a lot of those things in order. So it's been a great experience having that offloaded to her. And it just keeps things flowing, and having those relationships in place so we can send you guys out. And as we gain affiliation sites, we are creating a list, and we will have a practicum orientation in the fall, usually about October, maybe November. And it'll be a webinar like this, and I give a presentation on that. And if you're signing up to take practicum in the spring, then you'll have to attend that to take practicum. We have a question from Edmond. I live in North Dakota and work at a mental health I'm not sure that. I really aspire to grow into this field. Great. You want to continue your education, completing a bachelor's program, which we offer online too, and you can complete your practicums in your locale. So in North Dakota, I've had people in New York, Georgia, Tennessee. I think we've got a student right now in, I can't remember, somewhere in Africa. It's pretty amazing when you think about it, that what we're able to do with this technology. And of course, to become licensed as a substance abuse counselor in the state of Nevada and most states, you require a bachelor's. So an associate's gets you started, a bachelor's gets you licensed, and at a specific level of as a professional, and then a master's will get you to licensed independently. So in my practice, like I have a small private practice in Las Vegas, I can see patients, I can diagnose them for every mental disorder there, pretty much. And except for some things that maybe I'm not trained to do, like neurological testing, things like that, I would send that out to a psychiatrist or a neuropsychologist. And I can provide treatment. If it's something I'm not familiar with, I don't do a lot of, like maybe say eating disorders, I might refer that out to a specialist that I work with in that area. So it's a great field. There's a lot of opportunities to find what you're passionate about, what specific area you want to work in. Do you want to work adjunct with medical? Do you want to work in specifically human services agencies? Do you want to work with a specific population? There's just so much for us to do. Oh, that's nice. Somebody said that they couldn't ask for a better professor. I couldn't ask for better students, so the feeling is mutual. Any other questions, comments? I don't want to ignore the crisis we're under. These are extraordinary circumstances. I've never seen anything like this in my life. And I hope that y'all are aware that I'm willing to be flexible and understanding as things go forward. If there's an issue, if there's a concern, please reach out to me. If it's a legitimate concern, I'll work with you. Hopefully you're enjoying your semester so far. We're coming up on spring break. I try not to give you guys a lot of homework over spring break because I really do think as a mental health professional, rest, relaxation, and rejuvenation are an important part of a healthy lifestyle. So when I was in college, they would just pack the homework on you. Like big assignments were due, papers were due, big projects were due. I try to move those dates around so that when you come back, you're not piled on it, because overstressing an individual isn't necessarily lead to better learning outcomes. And I know that as a mental health professional and as an educator. Okay, so will we be getting graduation info, ordering cap and gown, since it isn't until May with everything going on? Yeah, I don't know. I don't have any information, so I don't want to give my guess because it could be misinformation. You'd have to wait to see what the college sends out. I really do hope graduation happens, but I'm not sure what's going to happen. Shane is asking about the assignment. So at the end of our before we go, everyone's still on. We got 41 folks on here, which are all, I will give you the passcode. And the passcode, you will go into your assignment for your course, and you will type that passcode in, submit it, either through the online submission or through a document or whatever. It's just going to be a password. And then that you get credit for attending the presentation or the symposium. And that's how we do it. It's really simple. I try to lighten up your assignments this week. So you'll probably notice that. Okay, so I think any more questions before we go? We're about 7 minutes away from ending. I'll give you the passcode now. Wash your hands, wash your hands, wash your hands 3 times. That's the passcode. Put that in your assignments, in your courses. If you have multiple classes in human services, you get credit in each class for the assignments. If you weren't able to attend, you wouldn't be here. But the way it goes is if you can't attend, I upload this presentation to YouTube. We provide a link in the assignment, and then you write a 2-page summary. So it's a lot less work for you guys if you come to the presentation. I know not everyone can always come at this time, so I try to make it accessible for everyone, so that everyone can participate in some way. Yes. Thanks, Brianne. Okay, folks. Remember the passcode. Wash your hands 3 times. Wash your hands, wash your hands, wash your hands, so nobody forgets. Stay safe, everyone. Please comply with the precautions the governor has suggested. It's the only way to curb this outbreak and keep yourself safe, the public safe, the community safe, and I'm sure we'll get through this, as humans always are, facing difficult challenges, but are resilient through them all. Thank you all. Have a great night. And I will see you guys online.